Good evening, everyone, and welcome to Kordofan Breast Cancer Campaign Symposium. I am Taqwa Saeed, and I'm deeply honored to be here with you tonight to support a cause that deeply impacts lives within our communities. As we gather here during Breast Cancer Awareness Month, our aim is to increase understanding, break down stigmas, and foster a supportive environment for patients, families, and healthcare providers alike. Together, through education, compassion, and collaboration, we are advancing a shared goal to reduce the impact of breast cancer through early detection, comprehensive care, and support for all. Welcome, all our participants today and all our speakers. Our first speaker today is going to be Dr. Mohammed Ahmed Ajab. Dr. Mohammed Ahmed Ajab is a graduate of University of Khartoum, and he is a consultant internal medicine and assistant professor of medicine at University of Kordofan, Faculty of Medicine and Health Sciences. Welcome, Dr. Mohammed Ahmed Ajab, and the floor is yours now.
Thank you very much, Dr. Tawa, for this very nice and comprehensive introduction. And heartfelt greetings to all of our colleagues, all of the speakers, the honorable speakers, all of the honorable guests who attended this important session. Thank you very much, Dr. Abdullah Al-Khair, Dr. Al-Shami, Dr. Abu Al-Aiz, Dr. Muhammad Fawzi, Dr. Tagwa, Dr. Afaq, and Dr. Safa, Dr. Mustafa. You are all cordially welcome to this very important symposium regarding breast cancer and regarding the activity of Kordofan Breast Cancer Campaign. I thank you all, and I hope you are going to enjoy this session and to have a good stay and good time with these honorable speakers. Some of them are our classmates, Dr. Abdullah and Dr. Shami, and we are very fond of them decorating this session. Thank you very much. I am going to talk about empathetic communication in a very difficult situation lived by our countrymen and our country, which is war-stricken now. The devastating war has damaged all of the infrastructure of our country, and now our area is entirely disconnected. Okay, the issue about which I'm going to talk is empathetic communication with breast cancer patients, enhancing care through compassion. I'm going to give a short introduction. I will talk about understanding the emotional landscape, core components of empathetic communication, following up with compassionate care, training healthcare providers, benefits of empathetic communication, and then I will give a conclusion and a chance for questions and answers. Empathetic communication with breast cancer patients in the situation which we are living in Sudan is difficult. The situation we are living now is the situation of complete disconnection. We are completely disconnected from our patients, whether they have breast cancer or any other chronic problem or even any other emergency problem. And this is the main challenge faced by us in these days. The impact of compassionate communication on patient well-being could not be ignored. Understanding the emotional landscape of breast cancer patients is important. The breast cancer patient is surrounded by a lot of dilemmas, including fear, anxiety, change in body image, concerns, and vulnerability. The importance of recognizing and validating the emotions and the concerns of breast cancer patients are crucial. Core components of empathetic communication, there are so many, but I will give the main of them, which are active listening. You need to actively listen to your patient, giving full attention without any interruptions or any inconveniences. Reflective responses, you need to acknowledge the feelings of the patient, and you need to give an considerable consideration for his problems. Non-verbal cues are important to look for and important actually to pay attention for. Body language, eye contact, and tone of voice, they need to be assessed and carefully attended to. Empathetic communication is not only hearing by your ears, but it is also you need to listen with your heart, and you need to feel with your heart, and you need to empathize with your patients, because breast cancer patients is a very special patient. The four elements of empathy are: you need to visualize the world of your patient, to assess the surroundings, the social environment, and of course, you need to explore the emotional landscape of your patient. You need to appreciate them and to know about them in depth, and you don't need to be judgmental. Understanding the feelings of the patient, and then you communicate your understanding to the patient, and this will create a very emotional healing environment for breast cancer patients. Providing information with sensitivity, you need to deliver information in small pieces and in manageable steps. You need to avoid medical jargon. You need to use simple and clear language so as to establish a very good doctor-patient relationship. You need to check for understanding and encourage questions. You need to give a chance for your patient to be listened and heard. Supporting decision-making by good empathetic communication, the patient is going to be engaged and is going to be part of the decision-making process, especially this is regarding his treatment, and you need to consider the autonomy of your patient. Respecting patient autonomy and involving them in every choice is crucial. Offering emotional support and validation in decision-making is essential, and involving family and support networks when appropriate is also important. Offering reassurance and encouragement, recognize and acknowledge patient strengths and courage, and you need to touch on the positive side in the patient and the strong points in the patient, as well as you need to strengthen the weak points of the patient. Reinforce progress and celebrate small victories. If the patient is improving, you need to celebrate that, and you need to acknowledge the cooperation of your patient and the patience of your patient as well. Statements like "you are doing incredibly well" can be therapeutic and moral. Encouraging open expression of emotions, creating a safe space for emotions, sadness, anger, and frustration is very important. Responding compassionately to emotional reactions is crucial. It is okay to feel this way, validating the patient's journey. The emotional journey of the breast cancer patient is a difficult journey. Following up with compassionate care. Compassionate care is the progression in the empathetic care. The last step in the emotional reaction and emotional support of the patient is starting with sympathy going through empathy, you will end is in compassion. So compassionate care is very important. Regular check-ins on emotional well-being alongside physical symptoms, and this will relieve the suffering of the patient. Providing resources, counseling, support groups, and online communities and online support is very important in critical situations like the situation we are living now in our country. Training healthcare providers is very important. Workshops are role-playing. Practice empathy in a controlled setting, like in a hospital setting, is very important. Feedback and reflection, you need regularly to review and improvement of skills of the trainees is very important. So you need monitoring and evaluation of your trained healthcare providers. Benefits of empathetic communication: it builds patient trust and comfort. It reduces the anxiety of the patient. It enhances patient satisfaction. It improves adherence to treatment, and it fosters a healing environment for the patient. As I mentioned before, sympathy progress to empathy, and the difference between sympathy and empathy is very important. In sympathy, you say to the patient, I am sorry for you. While in empathy, you will say to the patient, I am moved by you. In sympathy, you feel for your patient, and in empathy, you feel with your patient. So empathy and compassion are development in the doctor-patient relationship. It is a sort of a healing relationship that the patient is waiting and the patient needs. In conclusion, empathy is essential for effective breast cancer care. Compassion and communication supports patients' physical and emotional journeys, which is a very difficult journey. Encouragement to implement these practices in daily care is very crucial, and training of healthcare providers in managing breast cancer patients, training them in effective, empathetic, and compassionate communication is very significant and very important. And I will stop here for questions and answers. And thank you very much. And this is our Faculty of Medicine, University of Kordofan. Thank you very much for your patience and for your listening.
Thank you very much, Dr. Mohammed Ahmed Ajab, for this elegant presentation and very important. The next presenter, now I would like to introduce Dr. Mustafa Al-Noor. He is Assistant Professor, University of the Khartoum, Faculty of Medicine, Consultant Radiologist, Interventional Radiologist at Soba University. Please, Dr. Mustafa Al-Noor, welcome. And I hope all we are join and enjoy and learn from this presentation. Dr. Afaq, Dr. Mustafa, presentation is going to be a recorded one. So just let me share it.
So to start with, we have the triple assessment of the breast. As we all know, this is history taking and physical examination, then followed by imaging and intervention, for example, biopsy. My talk will cover the latter two. Concerning imaging, mainly we have three different imaging modalities when dealing with the breast or with the breast. We have the ultrasound first, we have the mammogram next, and we have the MRI as the third and last modality. So which modality we choose, this depends on many factors. The first factor is the availability and the cost of examination. These are very important. And most importantly, the age and symptomatology of the patient, because uh, anyone above the age of 35, it's better to go for mammography than ultrasound. The most important thing is the expertise of the radiologist performing and interpreting the study. In addition, of course, to contraindications and limitations, every study, as we all know, has its contraindications. So when there is a contraindication, this this is a limitation. We have this word, the BIRATS. BIRATS stand for Breast Imaging Reporting and Data System. This is a final assessment category. It's made to make things easier for the one reporting mammography or ultrasound or MRI. Almost same criteria are being used in every imaging modality. And of course, there are things that are readily seen by mammography that are not seen on ultrasound, seen on MRI, not seen on mammography, etc. طيب BIRAT 0, this is an incomplete assessment and you need additional imaging evaluation. BIRATS 1 is a negative, no further workup. BIRATS 2, this is a benign lesion like fibroadenoma or cyst, no further workup. BIRATS 3, this is probably benign. BIRATS 4, suspicious. BIRATS 5, highly suspicious. And BIRATS 6, this is biopsy proven malignancy. طيب, first of all, um, mammogram is used as a diagnostic and as a screening modality. It's done for those ladies in which we find an abnormality, or we have found an abnormality on screening mammograms. We do for them the diagnostic mammogram. Patient or physician has identified a breast lump. In patients with breast pain, tenderness, or when you suspect an abscess, it's better to go for ultrasound first and aspiration. In patients with spontaneous nipple discharge or new nipple discharge or changes, we need to go for mammography. The positions, we have two positions when doing the mammogram. We have the craniocaudal and we have the mediolateral oblique. This one is called the Milo, and this one the CC. This is the left breast. Each one has assessment criteria for accuracy or for diagnostic reliability. And this is a mammography machine. This is how we do the test. This is the patient, of course. This is the breast. This is a cassette. This is a compression paddle. So when we do the images, usually we review mediolateral obliques back to back and craniocaudal views also back to back. We put the right breast on the left side of the viewer and the left breast on the right side of the viewer. As in all imaging modalities, left of the viewer is the right of the patient and right of the viewer is the left of the patient. We put them like this. So these are the Milos and this one or these ones are the CCs, craniocaudals. Then we look for this, for masses, for asymmetry, for skin thickening, for calcifications, architectural distortions, for lymph nodes, for solitary dilated ducts. For example, this is a right breast. This is a milo view. We can see the pectoralis muscle here. There is no skin thickening, but we see this well-defined, smooth, well-marginated opacity. Again, we have Milo and CC views, both right and left breast. We have an abnormality here. It's shown also here in on the CC. We are dealing with the spiculated lesion. Again, this is a CC view of the right breast. Clearly, we see the thick skin. So we have remarkable skin thickening, and we have benign calcification, ductal, branching ductal, or vascular. These are benign calcifications, but we have very thick skin. So the benign calcification pattern, we have micro and macro calcification pattern. And for example, this is popcorn-like calcification. It's kind of benign calcification. This is a mammography, of course. This is a CC view of the right breast. So we have a benign pattern calcification. The malignant calcification looks like this. We usually have fine pleomorphic pattern. This is some sort of malignant calcification, and this one is a zoomed out view. It's a magnified view, of course. Sorry. So now we come to ultrasound. Ultrasound is a very important tool. It's cheap, it's readily available. When we use ultrasound, we don't use any machine or any probe. Machines that are being used on breast are dedicated machines. Usually we use a linear probe because it's a superficial organ. We call it small part in ultrasound. It's not small concerning the size, but it's superficial. So when we do ultrasound, we have different patterns. We have echogenicity, we have the shape, we have the margin, we have the orientation, we have the enhancement, and the presence of calcification. So here we have a cyst. It's purely anechoic. It's well defined, no calcification. It's horizontally located. The fibroadenoma looks the same, well defined, horizontally located, length greater than depth. It looks quite benign. Cancer is spiculated with hazy margins, indistinct, with microlobulations, with the spiculations. And most importantly, we have the vertical orientation. And frequently we have posterior shadowing in cancer. And while that one is the normal breast parenchyma. It's hyperechoic, locally prominent glandular tissue. I go to the MRI. MRI is, as I said, a problem-solving tool. It's not used in all patients. Used in certain patients. It has its indications. The most important one is the characterization of lesions, and to discriminate between benign and malignant lesions. MRI is being done with contrast. So we do pre and post contrast scans. We have dedicated coils. So this is a lesion here. We can see it on MRI in a pre-contrast. When we did the post-contrast, it got enhanced. So there is enhancement, pre and post-contrast. Now I go to the intervention. Concerning intervention, we have simple interventions like ultrasound guided procedures. We have, in addition to those, more sophisticated procedures like ablation. We have more sophisticated endovascular interventions for patients with metastatic deposits and so on. So for aspiration and biopsy, we use ultrasound. We aspirate cysts. This is the most commonly done procedure. So here we have a cyst. Ultrasound shows the cyst very clearly. Then we put our needle using the ultrasound guidance. This is the tip of the needle inside the cyst, and we aspirate the contents of the cyst. So at the end of the procedure, we have this no cyst at all. It has been totally aspirated. Secondly, this is how we do the things. This is our probe. Here we have two regions, one superficial located and the other one deeply located. We use what we call the on-plane technique. Secondly, so this one is superficial. Type breast biopsy using percutaneous needle has its indications. We don't do it for benign lesions. We don't do it for fibroadenomas at all. We do it only when there is a suspicious lesion, because if you would like to do it for fibroadenoma, the cut comes out as dry. Nothing comes out because it's very tough, and nothing comes out with the cut. Whether core or fine needle, this depends on the local expertise and the guidelines. But in most patients, we do the core biopsy. We don't do the fine needle. Indications: mass, distortion, or microcalcification. Okay. These are the benefits of ultrasound. It's ideal because of this real time. You can hold your probe with your hand. It's strongly reflected from metallic objects. That all those makes it suitable to do this, to be used as a guidance tool. We do it under local anesthesia. For example, here we have a lesion and we have a needle. Here we have a lesion and we have the needle inside the lesion, and we use the guidance through the ultrasound. So we advance our needle inside and we took the biopsy. This is a cath lab while we're doing the vascular interventions. And here, this is radio frequency under general anesthesia, of course. Again, radio frequency under general anesthesia in CT, in a CT room. So we use different modalities to do different kinds of procedures. Now this is the end of my presentation. Thank you very much. Assalamu alaikum wa rahmatullah.
Thank you very much, Dr. Mustafa Noor, for this nice presentation. And sorry, الصوت شوية كان منخفض. Our next speaker is Dr. Safa Hassan. Dr. Safa graduated from University of Kordofan, Faculty of Medicine and Health Sciences. She is a consultant obstetrics and gynecology at Doctors Without Borders in Canada, and she is a principal investigator in London School of Hygiene. Dr. Safa, welcome, and the floor is yours.
Thank you everyone. السلام عليكم كل الحضور. نتمنى إن شاء الله البرزنتيشن يوصل المعلومات البسيطة إن شاء الله اللي حابة أشارككم. Let me share my screen وإن شاء الله المؤتمر الجاي نتمنى يكون في سوداننا عامر بالخير من غير أي حرب، من غير أي مآسي، من غير أي دموع إن شاء الله يا رب يا كريم. ظاهر السكرين؟
أيوة يا دكتورة.
ظاهر؟
أيوة.
أوكي تمام.
أيوة بس.
I'm Safa Al Hassan. I proudly to say graduated from Kordofan University, batch 8. Currently, I'm a consultant of Sanghaini with both carrying my graduation from Sudan and training in Sudan Specialization Board. And I have my Canadian credential as well. Currently working with Doctor Without Border. As you can see, those photos, the first one for me in Faculty of Medicine, a couple of years ago, don't ask me when. And the second one is recently in my mission to Afghanistan, helping women in need. So my disclosure, I don't have any actual or potential conflict of interest in relation to this presentation. So what my target of point I would like to share with you today is caring for women who suffered breast cancer, either in pregnancy or shortly in postpartum period, and mainly concerning with lactation and throughout her reproductive age mainly. There is some issue about the fertility, either from the breast cancer treatment or the intervention as adjuvant therapy later. And for those who survive to postmenopausal, also we have some recommendation. Let's talk about the first, what we can call gestational breast cancer, as defined as a breast cancer, which the name implies is occurring mainly during pregnancy or in the first postpartum year. And it could be involving the lactation if the mother using the natural breastfeeding method for feeding her baby. So usually as a obstetrician, we are part of multidisciplinary team, and usually that team include all people who involve in management of women who suffer breast malignancy. And usually the treatment will be in concordance. Like usually we don't have a specific recommendation other than the treatment can be as a non-pregnant women. It just we need to have some modification in order to protect the baby from the effect of medication that can be used. And if the stage is early stage, usually we can recommend the conserving surgery for the breast. However, if mastectomy have to be done, So we don't have any other option to agree with other healthcare provider to reach the optimum management for women and having a great outcome for her. So during pregnancy, if the surgeon opt to have axillary node evaluation, sentinel biopsy, whichever is the method, we don't have any objection to that, and we recommend it to know which stage the women at now currently. With regard to adjuvant therapy, and mainly after delivery, we can discuss to postpone that after delivery. And if the other team members, including the oncology, they suggest to have the chemotherapy earlier during her pregnancy, we can ask to avoid the 3 to 4 weeks period, mainly during the neonatal, so we can avoid myelosuppression or potential complications that can happen to growing bone for the infant or neonate. With regard to breastfeeding, usually during the time she receiving the chemotherapy or endocrine therapy, our recommendation to use alternative way of feeding her baby to avoid transmission those medication to her baby. However, after finishing her treatment, it will be safe and feasible to continue the breastfeeding. As you all know, the breastfeeding is very important for growing infant and with all this benefit. What's the prognosis? The prognosis usually is great and they have great outcome as in non-pregnant women. So the pregnancy by itself cannot be a detrimental factor. However, the women who suffer in the postpartum period, some research suggests that could link it to a worsened outcome. But up to this time of presentation, I couldn't locate strong evidence. Researches need to be done here. With regard to fertility after breast cancer treatment, why we concern about the fertility? As you all know, with management, which could be either surgical treatment or adjuvant treatment, which could be chemo or radiotherapy, the ovarian tissue as growing cell tissue could be damaged if we couldn't have that conversation with the lady before. So we have to understand now she in a stage of breast cancer and she will go through this treatment. However, we can ask her about her fertility future, and that will determine which way we can go after completing her breast cancer. And that need a multidisciplinary team involving mainly the reproductive endocrinologist, especially for young breast cancer survivor. May be having issue after if those measures have not been done before after they finishing their chemotherapy, mainly those who are toxic to the gonads, or could delay their potential carrying pregnancy in the future. So we need to have that conversation and determine which is best for her future fertility. So our recommendation, if the lady or the woman have the breast cancer during her reproductive age, to delay the pregnancy at least for 2 years from the time she has been diagnosed to time she has finished her treatment. And that is necessary to avoid the cancer recurrence and complication. And with regard to adjuvant chemotherapy, and I know that will be a great topic for other speaker, but to which we can say related to obstetric and gynecology, at least if she is taking hormone receptive hormone treatment and she is receptor positive, so we need a delay at least 3 months of cessation tamoxifen before attempting pregnancy. Why that? In order to avoid any potential congenital malformations that can happen to her upcoming pregnancy. So, what's the regulation with regard to contraception use? As you know, contraception, most of them, they are hormonal, either pills or injections or IUDs. However, there is other non-hormonal. For to be in the safe side and not to complicate the option for the breast cancer survivor, so opting to non-hormonal contraception as like barrier method, condom diaphragm, and copper IU intrauterine contraceptive device will be a best option. If any need to use those hormonal, so we can go with hormonal contraception, which contain least amount of hormone, so we can avoid any interaction. So any treatment, as you all know, containing side effect and risk. So what we can monitor on the women when she came back to us during pregnancy after her treatment. So usually we anticipate could be have a cardio metabolic effect. So we have to examine her thoroughly, examine her heart, her lungs, measure her blood pressure, and investigate and ask her about symptoms of diabetic or any dyslipidemia and other pregnancy or postpartum screening as appropriate. So as a physician or healthcare provider, all of us have the responsibility to optimize our patient care, and that we can do it through physical, mental, social, economic, and spiritual aspect of life. We can encourage the women to be mobile, active, exercise every day, and enjoy the things that she like, talking with others, taking care of her mental, especially wherever um, they can go through depression or difficult time. So being here for her will be very supportive. So this point is also for the women who opt to like further who opt to have fertility preservation. So there is different options we can talk, as I just highlighted initially. So it could be embryo cryopreservation or oocyte or spermatozoa cryopreservation, and all this method in conjunction with infertility and reproductive specialist, and it could be costly. So we have to determine which is suitable for the patient. There is an option of surgery can be done, which is ovarian transposition and shielding. Why that can be done? The idea, we taking the ovary from the area of radiation and put it away and reposition it back. So that can help in still we having the ovary. It will minimize early menopausal stage for her, and it can enhance her ability to have natural pregnancy rather than assisted reproductive technology. Oocyte can be also. So all this method is just a detailed method that can be done by reproductive endocrinologist. Ovarian tissue preservation also can be. Embryo, as I said, and this is regarded as the longest used fertility preservation technique, and it could be not medically feasible for all patients. So the last point, if the lady approaching the menopausal stage, which could be her option, mainly the idea is the same. We just try to avoid hormonal, and especially on those receptor positive. So avoid the hormone replacement therapy, reducing vaginal dryness can be with non-hormonal moisturizers. They can use, if they have any, they can use a physical dilator, or if we have to use the hormone for any reason, it could be the low dose, and usually could be other options, psychotherapy and other alternative method. So that have being said, I reached to the end of my presentation, and my encourage for all of healthcare professional, learning and researching are essential part for caring our patient. So don't hesitate to contact me if you have any additional further question. Here is my email. This is a reference I used to build up this presentation, and thank you for listening. And I'm so happy, proud of having the opportunity to be here. Thank you.
Thank you very much, Dr. Safa. We really enjoyed your presentation.
Thank
Um,
you.
Thank you very much. This is very important topic, and I remember the last patient I saw in White Nile State. She was a 30 years old female, pregnant in her 7th month or in second trimester, and she firstly presented to me with unfortunately advanced breast cancer, and she was even not aware of being pregnant. So that was really challenging for all the staff in this situations we suffer in Sudan. Thanks again, Dr. Safa. Dr. Safa's presentation on breast cancer care in reproductive age women was both insightful and crucial. You highlighted the importance of early detection and you tailored care, emphasizing that young women face unique challenges, including the fertility consideration and psychological impact. Also, she focused on awareness and education and to empower women to seek screening and to understand the genetic risk and engage with health care proactively. Thank you very much, Dr. Safa, again. And our next presenter is Dr. Afaq Umar. Dr. Afaq Umar is a registrar of Just Medicine, and she is also a content creator with her own page called رئتان وقلب. Maybe some of you came across it. Welcome, Dr. Afaq, and the floor is yours now.
السلام عليكم. شكرا دكتورة تقوى على الانترودكشن الجميلة دي، وصراحة أنا قبل ما أبدأ البرزنتيشن بتاعي حابة إنه أعبر عن مدى فخري للكوردوفان بريست كانسر كامبين بقيادة الدكتورة تقوى، وكمان مقدرة جدا للحضور استقطاعهم من وقتهم عشان يحضروا ويستفيدوا. وطبعا الشكر موصول لكل البصات والبروفات معانا الليلة، حنستفيد منهم إن شاء الله كثير. في جملة دائما بحب أقولها إنه لو بين النوليدج والكلينيكال براكتس معناه إحنا ما فدنا، معناه على الكلينيكال براكتس معناه إحنا ما أفدنا المريض بتاعنا. وأتذكر دائما في الراوند أو في المرور لما الدكتور يقول لنا أنا جاتني في العيادة مريضة، دائما كلنا بنركز معاه، صح؟ ليه؟ لأنه بنكون دايرين نعرف أنت عملت لها شنو، الهيستوري كان شنو، الاكزامينيشن كان شنو، الانفستيجيشن طلع فيها شنو، طيب يا بص الابروش بتاعك كيف. وزي ما دايما بنقول يا بص في نهاية الحلقة الدياجنوزيس كان شنو. فاحنا دائما بنستفيد اكثر وبيرسخ في اذهاننا لما يكون في كلينيكال او ستوري. فالليله صراحه انا عندي مسج مهمه شديد دايره تصل ودايره تتحول من نولج لكلينيكال براكتس. عشان كده الكيس برزنتيشن بتاعي حيكون عباره عن ستوري حابه كلكم تركزوا فيها عشان طالبه منكم حاجتين. الحاجه الاولى الحاجه الثانيه طالبه انه في نهايه السيشن هقول لكم point to the mistake. تمام. let's start. حاجة حيكون in the title of from mistaken identity to diagnosis, a surprising journey from tuberculous plurifusion to a serious disease. طيب الستوري حقتنا حصلت في one of the villages in Sudan. One of the villages in Sudan, I was working as a registrar. One day, a 44-year-old lady came to our crowded outpatient department with increasing dyspnea for the last month. According to the patient, she had no respiratory problem before that month. The dyspnea was initially on exertion, but it progressed rapidly, and at the time of presentation, the patient experienced dyspnea even at rest. She did not have fever, hemoptysis, or even chest pain. The dyspnea increased when supine. The patient had distressing cough. The patient is teacher and non-smoker. طيب في examination general examination, the patient was dyspneic with accessory muscle using. Her blood pressure 100/70. Patient was tachycardic and tachypneic. البلس كان 106, respiratory rate 32. But the saturation maintained 99. No other positive finding in the general examination. نجي respiratory examination. There is decreased movement on the left side. Trachea was central and slightly to the right. Percussion notes were dull over the left mid and lower lung. Absence of breath sound over those dull areas. An examination of other part of the lung was normal. There is no hepatosplenomegaly or even peripheral lymphoadenopathy. So يا جماعة, what is your clinical diagnosis from the history and examination? لو في دول برا يورينا ممكن يكون الكلينيكال diagnosis شنو؟ طيب نمشي للانفستيجيشن. طيب CBC, the patient hemoglobin was 8.5, MCV 33, sorry, MCV 80, ESR was high 60, and other blood tests were normal. So the patient obviously has anemia. The type of anemia is normocytic normochromic anemia. فممكن هنا نفكر بما إنه العيانة عندها anemia with high ESR, ممكن نفكر عندها chronic infection or anemia of chronic disease, right? طيب the next step طوالي حنعمل chest x-ray. I want from you this chest x-ray to describe the lesion and to give me the radiological diagnosis. في أي زول متطوع ممكن يقرأ معايا ال chest x-ray؟ شباب تقوى جاوب انت. يلا يا جماعة عايزينه interactive session. الحاجة الobvious.
أنا شايف يعني homogeneous opacity on the left side of the lower left side of the chest. most probably يعني left sided pleural effusion moderate.
Yes, exactly. Yes, moderate. Exactly. You are totally right. Thank you very much for your sharing this. Describe the lesion. The doctor said the lesion showed homogeneous opacity in the left mid and the lower zone with obliteration of the left cardophrenic and costophrenic angle. لو لاحظنا ال upper border of the effusion زي ما قال الدكتور convex. وبس هنا حنجيب في حاجة إنه دائما البرو effusion بيكون ال upper border بتاعها concave بنسميها المنسكن ساين. So لما يكون ال upper border convex إحنا فكرنا أكتر حاجة ممكن تكون insisted pleural effusion. فماشيين في التراك الصح تمام. So the radiological diagnosis is insisted pleural effusion. وزي ما قلت إنه الفري pleural effusion هنلاحظ إنه ال upper border بيكون concave upward and medially والhighest point بتكون to the axilla في حين إنه ال insisted pleural effusion بيكون ال upper border is a convex upward والhighest point ما بتكون to the axilla. فمن هنا قلنا ممكن most probably the diagnosis is insisted pleural effusion. زي ما احنا قلنا احنا قاعدين في village in Sudan. So ممكن يكون ما عندنا الفاسيلتيز بتاع الالتراساوند or the CT. What is the most next step بعد ما نشوف الchest X-ray احتمالية إنه ممكن يكون في pleural effusion. The next action طوالي حنعمل pleural tap. Yes. طيب ودائما لما ناخد البلورال تاب أو البلورال aspiration بنتوقع إنه حنلقى effusion تمام عشان عايزين نشوف الكلر الجلوكوز البروتينز اكزوديت ترانزوديت عايزين نشوف هل في malignant cells هل في بكتيريا لكن السبرايز كانت في الكيس بتاعتنا إنه when attempt to aspirate the pleural effusion in the outpatient department there was a dry tap يعني ما طلع معانا effusion and repeated attempts failed. So I advise the junior doctor to prepare a slide with a bloody material and send it to the pathology department. تمام؟ عايز أسأل بس سؤال what are the cause of dry tap؟ يعني إذا أنت كنت قاعد في الحوادث زيي وجاك مريض وقلت الchest X-ray دي عبارة عن pleural tap وجبت النضل وسحبته وما طلعت لك حاجة تتوقع ممكن يكون الدياجنوزيس شنو؟ أو الحاصل شنو؟ ممكن زول يشاركنا أفكاره؟
It could be wrong diagnosis.
Yes. Yes, you are totally right. What else?
ممكن يكون very thick fluid.
Excellent, excellent. Very thick fluid, yes. طيب ممكن يكون زي ما احنا خدتين إنه هي insisted pleural effusion وممكن يكون emphysema with thick pus لكن احنا استبعدنا الاحتمال ده لأنه البيشنتس ما كانت توكسيك ولا كان في فيبر ولا كده. ممكن يكون في needle blockage ممكن تكون الإبرة اللي أنت دخلت بها مقفولة وزي ما قالت الدكتورة ممكن يكون wrong diagnosis. So at this point my diagnosis is insisted pleural effusion وزي ما قلت unfortunately لأنه أنا قاعدة في village ف that time ما كان عندي لا ultrasound ولا CT. So إحنا عندنا حاجة اسمها clinical trials صح؟ يعني العيان لو جاك وفي احتمالية إنه يكون عنده نيمونيا مثلا ممكن تديه antibiotic احتمال يكون أزمة ممكن نديه inhaler احتمال التي بي ممكن نديه treatment for TB اللي إحنا خدتين الحاجة دي. وبعد ذاك نشوف الريسبونس. So since tuberculosis is the most common cause of cystic pleural effusion in our country, we start FDC اللي هي fixed dose combination and waited for the patient response and the report from the pathology department. احنا بعد كده كنا منتظرين البيشنت بعد كم يوم تيجي تقول لنا والله الديزنيا خفت ونشوف الانفيوجن في الجيس اكس راي improved. طبعا البيشنت I advised her to be admitted but the patient refused. في البروجريشن unfortunately العيانة بعد يوم جاتنا the patient retained with severe dyspnea and was unable to talk. I insisted her to be admitted to us. بعد كده كان عندي وقت أكتر إنه أنا أخذ details history. her brother mentioned that 2 years ago she underwent lobotomy at the left breast as the patient had breast tumor. فطوالي جريت وعملت examination in and out وشفت السكار دي. فمنو فيكم ممكن يقول لنا أو يتخيل السيناريو كان شنو؟ شايفين شنو في الصورة دي؟
Scar. The scar.
Yes. في البريست بنسميها inframammillary scar. Yes.
Scar under the breast. Scar under the breast.
Exactly. Exactly. It's an inframammillary incisions or scar. So when I re-examined the patient, I discovered an inframammillary scar, which unfortunately I had missed the crucial finding earlier in the crowded outpatient department, which طبعا ما excuse إنه outpatient كان crowded, I didn't examine the patient very well. فمن هنا نقول إنه the dry tap, the possibility of wrong diagnosis should be taken seriously, and the patient had a breast cancer that likely met to the lung, and what appeared to be a pleural effusion in the chest X-ray can actually indicate of mixed mass in the lung. So the end of our story, the subsequent report from the pathology department regarding the slide made from thoracic aspirate suggests the presence of malignant cells, most probably made from previous breast cancer. The pathologist recommended that biopsy performed from definitive diagnosis. محتاج ياخذ أو محتاج يعرف البيوبسي نتيجة البيوبسي أولاً. So I referred the patient to the oncology department in another city, but they refused to start chemotherapy طبعاً لحد ما تطلع النتيجة بتاعت البيوبسي. ولكن للأسف الشديد the patient passed away في اليوم السابع before the biopsy could be performed. So نرجع للسلايد بتاعنا لما قلنا what are the cause of a dry tap، وإحنا قلنا إنه دي عبارة عن tuberculosis in cystic pleural effusion, which is kind of wrong. The right diagnosis is wrong diagnosis. عايزاكم بس الناس اللي معي من بداية السيناريو from the history لحد النهاية point to my mistakes. عندنا 5 mistakes.
I think we should examine the breast first.
Yes.
We forgot to examine the breast, I think.
Definitely, yes. This is one of my mistakes. Yes. What else?
أنا أفتكر إنه الدياجنوزيس from the start ما ماشي مع typical chronic pulmonary tuberculosis. No fever, no sweating, no weight loss, يعني no clear symptoms of pulmonary tuberculosis. افتكر انه it is quite rare يعني for late stage tuberculosis to present like this, يعني sudden shortness of breath only for a couple of days.
Yes, exactly. And the dyspnea and the TB is very rare إلا إذا كان في massive pleural effusion ولا إذا كان في massive destructive lung. Yes. Exactly. The first mistake, I was ignored the intensity of dyspnea as زي ما قال الدكتور the incisive pleural effusion shouldn't cause this severe dyspnea. The second mistake is I missed the history of breast tumor and surgery. I missed the finding of surgical scar. The trachea, as the examination, it was to the right, but it is normal. The trachea central was slightly to the right. Does not mean always the patient has pleural effusion. And the last thing, I didn't adhere to the dictum examination of the respiratory system is not complete without examining the testes in the males and the breast in the females. This is my message today. So زمان بذكر البوصات كانوا بيقولوا لنا you are not treating the paper. زي ما قال الدكتور إنه البيشنت ما كان عندها fever. You are not treating the paper. هنا في respiratory حقول we are not treating the X-ray. والمسج الثانية المهمة إنه examination of respiratory system is not completed without examination of the testes in the male and the breast in the female. So our journey from mistaken identity at the case of incisive pleural effusion tuberculosis to the serious diagnosis of METS breast cancer. Thank you.
Thank you very much, Dr. Afaq, for this nice presentation, and يعني شكرا على الشجاعة. يعني it's not an easy to tell that I am mistaken, but we usually in medical field learn the hard way from our mistakes. I think you will never forget this patient, and everyone who heard today this lesson, this story will not forget it at all. Thank you again. Okay.
Dr. Shami, I would like to introduce Dr. Shami, University of Khartoum. He is a medical oncologist at Central Care Cancer Center at USA. Thank you very much, Dr. Shami, for your accepting our invitation. And I hope we all enjoy and learn from your presentation. Thank you.
All right. السلام عليكم مرة تانية. معلش صوتي تعبان. Just bear with me. Okay. So what I'm going to present is non-chemotherapeutic agents in non-metastatic breast cancer. This is my disclosure. Okay. So صوتي تعبان شوية معلش. Just bear with me. So I'm going to try to cover the non-chemotherapeutic agent in non-metastatic breast cancer. This is my disclosure. This is the landscape of cancer therapy over centuries. We started with his holistic and alternative medicine, spiritual, herbs, hormonal, chemotherapy around the World War II in 1940s. And in the 1970s, we have a new kind of therapy for cancer, trying to do things other than chemotherapy, which we could call precision medicine, targeted therapy, and immune therapy. So we're in the era of precision medicine. I'm going to cover cancer therapy other than chemotherapy. So, and mainly in non-metastatic. So new adjuvant or preoperative and adjuvant therapy. Targeted therapy, including endocrine therapy. Endocrine therapy is considered targeted therapy because it is an anti-estrogen and anti-HER2 directed therapy. CDK4/6 inhibitors, PARP inhibitors, and immunotherapy. Immunotherapy also is considered kind of a targeted therapy. And of course, chemotherapy is kind of fading away. And hopefully, we will never use chemotherapy in the future. So think about cancer cell as this ball, which has in the surface or the cell wall has some targets. Here you can see the most common breast cancer is ER and PR positive and HER2 negative. That's the three targets. So either estrogen, progesterone positive, and HER2 negative. That's the most common type of cancer. The other type of cancer is estrogen and progesterone negative and HER2 positive. And the third kind of cancer is negative for everything, doesn't have any target. So based on that, we divide our patients to try to treat patients according to these findings, 3 findings. So I'm going to cover the first common type, which is the estrogen progesterone positive, HER2 negative, and try to see what kind of targets and when we could use them. So we could target the ER and PR with hormonal therapy. So now, the adjuvant therapy versus chemotherapy. In the past, we used to just empirically try to find out and treat patients with chemotherapy or endocrine therapy. And that's based on the magnitude of benefit from chemotherapy. And that is based on the clinical feature, stage of the cancer. The higher the stage, we give chemotherapy. The lower the stage, we give endocrine therapy. The ER/PR positive, we give hormone. The ER/PR negative, we use chemotherapy. And the grade, low grade chemotherapy, low grade hormonal therapy, high grade, we use chemotherapy. That is our best guessing. However, nowadays, we use biologic features. We don't rely on the stage, ER/PR only, and grade only. So we use biologic feature by doing some kind of what we call gene expression profile of the cancer. So we use the tumor, extract the gene from the cancer and try to, instead of guessing, try to be more precise. So one of the best example of gene expression profile or multi-gene assay is something called Oncotype DX recurrence score. That they test 21 gene. Of course, there are other tests like a mammal print, but I'm going to use the most commonly used, which is the Oncotype DX. So we take the sample, test it, look for the gene, come up with a score. Kind of very complicated procedure, but that's as simple as that. This is just, I'm just going to go over it quickly. This is the score, how they come up with the score. The score is from 0 to 100. So for premenopausal now, if the node positive, regardless, if the score is 0 or 100, we use chemotherapy, period. We don't. So if this lymph node is negative, there are some studies show that is based on the score. So anything less than 26, we may use just hormone. Anything more than 26 to 100, we use chemotherapy. So now we are not guessing. We are more precise now. For the postmenopausal, on the other hand, if there are 2 studies show that if the score is less than 25, no chemotherapy, no benefit from chemotherapy. So we avoid the chemotherapy. In the past, we used to treat patients based on the stage of the cancer and give them chemotherapy unnecessarily. So based on this Oncotype DX, now we save many patients from getting chemotherapy. And at the same time, we give the patient the right treatment based on genetic testing other than just guessing. So for example, if the score is 26 to 100, we give them chemotherapy. So the Oncotype DX, so we don't use it for everyone. So when we use this genetic testing, so basically if the tumor is, of course, estrogen fed or estrogen dependent, and the decision of the chemotherapy is not clear, then we use it. But say, for example, if the tumor is very small, this is when you use it. If the tumor is not small, or the lymph node are positive, less than 3, then we use the test. On the other hand, when we don't use it, because this test is also expensive and it may not be available easily. So when we don't use it, if the tumor is very small, like less than 0.5 centimeter, lymph node negative, we don't have to use the test and give the patient hormonal therapy, and that's it. If the tumor is large, not positive, then we use the test to find to save patient from getting chemotherapy or give the patient the right treatment, hormonal or chemotherapy based on the genetic testing. Now, based on this, I'm just going to go and into the adjuvant therapy for the postmenopausal. If you have a postmenopausal patient, then we treat them. I'm going to cover based on the test. Let's just say it is hormonal therapy, not chemotherapy. So which hormonal therapy? Is it tamoxifen, the old drug, or the new version of the anti-estrogen, which is aromatase inhibitors? So this is the biggest study. They looked into the difference between aromatase inhibitors, anastrozole versus tamoxifen, and basically just it came back to anastrozole is superior to tamoxifen. Tamoxifen versus aromatase inhibitors, and these are the 3 aromatase inhibitors available in the pharmacies of the market: non-steroidal, anastrozole, letrozole, and steroidal exemestane. So can we use both of them? Can we use tamoxifen? Can we go back and forth? Yes, we do. We could use, I'm just gonna go quickly on this. Yeah, so we could use like 3 years of tamoxifen, 2 years of anastrozole. You can combine. So you can, because anastrozole is better, more effective, but side effects are bone loss and osteopenia or osteoporosis. So if you could combine this, I mean, 2 years, 3 years, 5 years, 2 years, you can combine those. That's okay. For how long you give the endocrine therapy? Minimum 5 years. Can we extend? Yes, but for certain patients. Who? Well, and instead of guessing, there is also a genetic test called breast cancer index. You can test the cancer gene, and you can the cancer test gene that can tell you if another 5 years could help or not. So it is a genomic test for early stage breast cancer. And that is they also give very comprehensive and complicated test. The test at the bottom line will tell you if the other 5 years is necessary or not. Because some patients, they would like to take it for 10 years, some patients, they don't. So here you can give them a precise decision saying that is another 5 years is needed or not. So it predicts benefit of extended endocrine therapy beyond 5 years. And also you could avoid potential over-treatment beyond 5 years. So this is also a test that is could help you to decide for how long you need to give the drug. So for the postmenopausal, you could give the endocrine therapy similar to chemotherapy to shrink the tumor, because all the time we believe that the tumor could be shrunken by chemotherapy, but it could be done with endocrine therapy also without a need for chemotherapy. And who are those patients? Candidates are patients unfit for chemotherapy, or patients with favorable features, cancer that is fed or hormone dependent, HER2 negative, low-grade tumor. Actually, they are studied looking at the chemotherapy, endocrine therapy to shrink the tumor instead of using chemotherapy. And this study showed that the response is similar, and it has also similar breast conserving surgery, and it's of course lower toxicity. And the survival not yet available. If you use endocrine therapy instead of chemotherapy, use aromatase inhibitor. Do not use tamoxifen. You could use it for 4 to 6 months. It is preferred, as I said, over tamoxifen. And there is no difference which aromatase inhibitor you could use. There's another clinical trial show that is actual anastrozole versus the injection hormonal therapy, fulvestrant. And that study showed that fulvestrant doesn't add much. Use anastrozole pills, which is less expensive. So for premenopausal, the adjuvant endocrine therapy, tamoxifen, of course, we do not use aromatase inhibitor, and we'll see why. And but if you use aromatase inhibitor for the premenopausal, then you have to use what you call ovarian suppression, ovarian function suppression, OFS, or ablation, of course. So why we do not use aromatase inhibitor alone in premenopausal? For a couple of reasons. Aromatase inhibitors basically are inactive while the ovaries are functioning. So they're not effective, the ovary is working. So aromatase inhibitor may also reactivate ovarian function, particularly in women with chemo-induced amenorrhea. Aromatase inhibitor has a negative effect on breast cancer outcome. Aromatase inhibitor alone is contraindicated, of course, in premenopausal. If you use it, you have to suppress the ovaries first before using it. This is just the studies that is about using the ovarian function suppression. There are 2 studies. They actually have almost 5,000 patients with ER/PR positive early breast cancer. The 5-year of exemestane and ovarian suppression versus tamoxifen and ovarian suppression. Basically, the bottom line, it showed that it improves survival and it improves disease-free survival. So if you use in the premenopausal, use endocrine therapy with ovarian suppression that use aromatase inhibitor with those. So it improves overall survival. For patients who are young, less than 35 years old, that's the cutoff for young. And then, or a patient with a high risk, this is a high risk lymph node positive, large tumor more than 5 centimeters, poor prognostic assay, or feature indicating that the patient needs chemotherapy. So for those patients, we prefer to use endocrine therapy with ovarian suppression, ovarian function suppression. And for the ovarian suppression, we use gonadotropin-releasing hormone agonists like Lupron or Zoladex, or of course ovarian ablation. So ovarian function suppression during and after chemotherapy, it should be, if it's used, use it during chemotherapy and after chemotherapy. So you combine it. So it improves survival for young patients less than 35 years old. For patients who are older, more than 35, or not high risk, you could use only endocrine therapy. You don't need to suppress the ovaries. But if you do, use it for average risk patient. Here I'm going to shift gears and go to another target, which is CDK5/6 inhibitors, and there are 2 of them used in the adjuvant setting, not metastatic. So these are 2 clinical trials, a monarchic trial. They have more than 5,000 patients. They use abemaciclib, which is Verzenio. And here the result of the study, it showed that it does improve the distant relapse-free survival, and it does improve the invasive disease-free survival. So it is effective. This is the indication for this drug, which is a non-chemotherapy drug for patients with the high-risk cancer. Another drug is ribociclib or Kisqali, is also used in the adjuvant setting, not for metastatic. It is not a chemotherapy. So these drugs are kind of replacing chemotherapy. This clinical trial published in New England Journal of Medicine, and it showed that ribociclib or Kisqali does improve disease-free survival, and now it's approved and in use. For the now we go to the premenopausal women. We try to see if we use something other than chemotherapy. So for the premenopausal, using endocrine therapy in the premenopausal is actually the data is limited, and there is only phase 2 studies that show that it doesn't really work. So for premenopausal, unfortunately, still we recommend chemotherapy as a standard of care, unfortunately. So for the new in the new adjuvant for the premenopausal. Now we go to a different type of breast cancer, which is the second group, which is regardless of the hormone receptors, it is HER2 positive disease. So that our target is the HER2, and these are the drugs that are used in the non-metastatic setting. So typically we use chemotherapy, but we add the anti-HER2 is still we use it in combination with chemotherapy. Hopefully in the future we could use it without it. But so far the standard of care is to combine it with the chemotherapy. And these are the regimen that we combine it with. And it could be anti-HER2 drugs, which is the trastuzumab, pertuzumab, or now there is a pill, neratinib. We use it as an extended maintenance therapy. Those are the patient candidate for new adjuvant anti-HER2, advanced disease, stage 3, stage 2B, or for some certain stage of stage 1 or stage 2. This is when we use another anti-HER2 drug. Basically, it's for local advanced disease, inflammatory breast cancer. This is actually we're trying to see if we can get rid of the chemotherapy and use anti-HER2 only. This is an ongoing clinical trial, phase 2 trial. They have 356 patients. and they use actually chemotherapy plus anti-HER2 drugs, and they combine them with no chemotherapy. And so far, there is no significant difference in event-free survival or overall survival. So if this study validated, we can get rid of the chemotherapy and treat only with immunotherapy or targeted therapy. So if it so still you could use it it's not approved yet, but you could use it if the patient refused chemotherapy or not candidate. Then you could use trastuzumab, pertuzumab, non-chemotherapy drugs in the new adjuvant setting. The last group of patients is the patient who has no target, nothing you could target, what we call triple negative breast cancer. So even there is no target, now we find something for them. For those patients in the pre-operative, premenopausal or postmenopausal, either. So for patients with a node positive or tumor more than a centimeter, this is a phase 3 Keynote 522, Keynote 522. This study actually changed the standard of care for the triple negative breast cancer. In this study, we use chemotherapy plus a drug called pembrolizumab or Pembro or Keytruda, and it found that actually patients who received this chemotherapy may end up with no evidence of disease after the chemotherapy. So complete pathologic response. So now it becomes the standard of care for those patients. So Keynote 522 is considered standard of care for stage 2, stage 3 breast cancer. This is an immunotherapy, not chemotherapy. So for patients who have the BRCA gene mutation, we add a PARP inhibitor, which is olaparib or Lynparza, for their if they are BRCA negative. This is a targeted therapy also. This is a study that led to the approval of this drug and showed that it's effective. It's a pill that is for BRCA positive patients. So olaparib or Lynparza, it could be used after surgery if the patient is BRCA positive, they have the BRCA gene mutation. This is my last slide, which is the take-home message. So we all need to make sure all breast cancer patients are evaluated for possible targeted and immune therapy. Why that? Because we target signaling proteins and immune pathways. Of course, require patient selection. That means we have to test the patient for those markers. And because immune therapy and targeted therapy has less toxicity, and it improves outcome from clinical trials and extend patients' life. And thank you much.
يا دكتور الشامي، أول حاجة السلام عليكم ورحمة الله وألف لا بأس عليك. You did a very excellent job, يعني very good and informative lecture concerning the management of breast cancer. أنا أفتكر you did very well. وطبعا this is what we expect يعني our expectations are in line with what you did. Thank you very much يا أخي، وألف لا بأس عليك، وعاجل الشفاء إن شاء الله، وعاجل الشفاء للسودان. يعني رفعت العلم في نهاية البرزنتيشن بتاعك. شكرا لك كثير دكتور الشامي. أنا محمد أحمد عاجل.
لا كيف الله يديك الصحة والعافية وشكرا لكم.
الله يسلمك يا أخي، والله مرحب بك.
ممكن أسأل سؤال للشامي لو سمحتوا؟
تفضل عبد الله.
الله يبارك فيك. الجين تيستينج عشان تهافد في في اللبيض ان شاء الله، يعني باعتبار انه السودان الخطوات والكوست يعني do you see that happening?
Yeah, I see that. Allah, I see that. the good thing about these tests are all kit. يعني
Okay.
so these tests are kit actually. يعني دائما بتكون طبعا في النهايه في البدايه مكلفه بس لانه نيولي ديسكفرد، لكن اديك مثال بسيط لان اقول لك ليه ممكن تكون تتوفر. يعني تتذكر البراكا 1 براكا 2، انا اتذكر لما كنا بنبداه وبنعمله قبل just say 10 15 years. انا اتذكر لما كنت we ordered it في اليونايتد ستيت it cost $5,000. كويس. طبعا ده لانه ديسكفرد. بعد شويه طبعا الكمباني they have to لانه كان عندهم بيتنت على التست. هسه الليله البراكا تيست جينيتيك تيست ب $200.
Yes, yes. Dr. Taqwa is a senior registrar of internal medicine, graduated from Kordofan University, and she is a director of Kordofan Breast Cancer Campaign. Welcome, Dr. Taqwa, and thank you very much for your efforts.
Thank you very much. شكرا جزيلا ومرحبا بكم جميعا. سعيدة جدا الليلة بهذا الحضور الأنيق، ويعني ما في أي كلمة ممكن توصف مدى شكرنا ومدى امتناننا لكم يعني for your support. وهذا يعني الجهد نسأل الله سبحانه وتعالى أن يتقبله، و it's a collective effort. I am Taqwa Saeed. I am graduate of University of Kordofan and the director of Kordofan Breast Cancer Campaign. I'm going to give you a few words about the campaign, and our theme is mainly raising awareness, promoting screening, and enhancing support. This presentation includes introduction, objectives, partners, activities, conclusion, recommendations, and acknowledgement. To start with, Kordofan Breast Cancer Campaign launched in 2023. This is the second year, and it mainly was an initiative from the Faculty of Medicine, University of Kordofan. It's mainly to address the growing needs for breast cancer awareness and early detection in Kordofan region. This initiative brings together healthcare providers, students, and community organizations to enhance breast health literacy and accessibility of screenings. Breast cancer remains one of the most common cancer among women worldwide, with early detection improving outcomes significantly. However, in areas with limited resources, many women lack access to essential information and screening facilities. This campaign addresses these barriers, aiming to save lives through education and support. The campaign primarily targets women in Kordofan region, but also engage healthcare providers, medical students from broader communities by fostering knowledge and awareness. The campaign encourages community-wide based support and support for breast health and cancer prevention. The primary goals of the campaign to increase awareness and education about breast cancer, promote early detection through screening and educational outreach, and to support those affected by breast cancer and their families. And also to train healthcare workers and do community mobilization and empowering medical students to lead health initiatives. The activities held this year were health education sessions, and those sessions were led by medical students, mainly focusing on education, awareness, and also there was free of charge clinics, both on site and online, and it provided services like screening, checkups, and consultations. There was also an academic session. This session was led by Unit B, Surgical Department in Al Ubaid Teaching Hospital. And also we had webinars, and there was posters and videos through the social media, and this is our last the virtual conference or the symposium, which is right now progressing. The partners mainly Faculty of Medicine, University of Kordofan is the the sponsor or the main sponsor of this campaign. And the Ministry of Health, North Kordofan State, Al-Ubaid Teaching Hospital, Sudanese Society of Breast Imaging, Sudan Sepsis Alliance, Tababa Transformation Center, University of Kordofan Medical Alumni Association, Khair al-Zad Humanitarian Organization, and also on social media we have صحة رئتان وقلب. And الناس اللي كانت معانا في the last campaign, if you can see, بحمد الله إنه يعني this year we increased the partners and we hope for more, inshallah. Each partner contributed to the campaign either through funding or logistic support or expertise in healthcare. Those were some of the activities اللي هي early detection breast cancer clinic كانت بتعمل weekly بواسطة وحدة الجامعة باء في مستشفى الأبيض التعليمي، وكان برضو في academic session weekly. those cards were designed and distributed to the patients admitted to the surgical ward in الأبيض Teaching Hospital. والعملت الكارد، يعني الكارد دي اتعملت made by medical students. يعني هنا دي الحتة اللي هي قالها في البداية كان دكتور عجب اللي هي حتة الcompassion، فده كان compassionomics. those were the webinars. معانا كان بروفيسور محمد المعتصم ودكتورة رباب أحمد from Sudanese Society of Breast Imaging, and Dr. Mohammed Al-Fatih was representing both طبابة and Sudan Sepsis Alliance. ده اللي هو our symposium وكل ال speakers. Recommendation from this campaign: we recommend to continue the annual awareness campaigns to ensure that the campaign is an ongoing effort increasing each year, and to strengthen the community engagement through continuous education and support. Also to expand collaboration with regional organizations, additional NGOs, local hospitals, and international organizations in order to increase the resources and the expertise. We also would like to seek governmental support to integrate breast cancer awareness into a broader public initiatives. And regarding the area of sustainable development goals, the campaign already aligned in 3 areas, but we need to increase it more. Regarding SDG 3, which is good health and well-being, we aim to align the campaign activities with global health standards to improve the outcomes. And regarding SDG 5, which is gender equality, we want to empower women through healthcare access and decision-making regarding their illnesses. And SDG 17, which is partnership for the goals, to expand the partnership to enhance campaigns, reach, impact, and sustainability. To conclude, Kordofan breast cancer has been instrumental to raising awareness and to promoting screening and providing vital support to individuals affected by breast cancer through health education sessions, free clinic, professional engagement, and campaign. Sorry, just excuse me for 1 minute. Sorry, excuse me for 1 minute. I'm sorry for the interruption. Can you hear me?
Yes, دكتورة تقوى.
Okay. Through health education sessions, free clinic, and professional engagement, the campaign has reached a lot of individuals, building a foundation for long-term health improvements. The campaign impact highlights the power of community collaboration in addressing public health challenges. And by continuing this work, and expanding the partnership, Kordofan can lead the way in breast cancer awareness and healthcare advocacy, saving lives and fostering a healthier future for all. At the end, I would like to send special thanks to all the partners of the campaign and all the participants. And I have to thank all our speakers for today. Dr. Mohamed Ahmed Ajab, the head of scientific committee of the campaign, Dr. Mustafa Noor, Dr. Afaq Umar, Dr. Shami, Dr. Mohammed Fawzi, Dr. Safa, Dr. Abu Al-Is. And I have to thank Professor Mu'tasim, Dr. Mohammed Al-Fatih, Dr. Rabab, and special thanks to Dr. Abdullah Khair for providing the platform for this event today. And I'd like to thank Dr. Qasim Khayal and Dr. Hind Al-Naim, my batch colleagues, who supported this campaign financially. And also, I would like يعني أود أن أترحم على أرواح من فقدنا in the fight against breast cancer. أترحم على روح my colleague, my senior colleague, Dr. Sama Harbi. We lost her recently for breast cancer. And also my batch colleague, Dr. Najla Muhammad, also يعني she gone because of breast cancer. يعني we dedicate this for their souls, and may their souls rest in heaven. والشكر لله من قبل ومن بعد، ونسأل الله يعني أن يتقبل الجهد من الجميع. يعني لولا وقفتكم كلكم ما كان الحاجة دي ممكن إنها تبقى، ودي أقل حاجة ممكن كان الزول يقدمها لبلده، اللي يعني إحنا طلعنا منها يعني مرغمين، ما كانت برغبتنا، لكن طلعنا منها ونحن شايلينها في جوانا، في كل ركن نحن بنشوفه، في كل حاجة جميلة بنتمنى شفناها في هنا في بلد، نتمنى إنها تكون هناك، لأنه أهلنا كلهم بيستحقوها. فالشكر لكم جميعا و thank you very much. ويعني أستميحكم عذري يعني إذا في أي حد أنا يعني اسمه يكون قد يعني سقط سهوا أو يعني نسيت ما قدرت أشكره، فيعني لكم العتبى جميعا حتى ترضوا. شكر لكم جميعا الحضور على يعني صبركم وتكبدكم لكل هذه المشاق. جزاكم الله خيرا جميعا وشكرا جزيلا.
شكرا يا دكتورة تغوى for the very elegant and emotional يعني presentation, very informative, and you told a very important story of this Kordofan breast cancer campaign. وأنا أفتكر this is a great success يعني now يعني by this session this is a great success و very considerable effort يعني في جو عايشينه نحن في وضع الحرب والوضع المأساوي اللي نحن عايشينه. فأنا أفتكر إنه this is very great. We thank you very much for this effort. أنت والكوليكس بتاعينك دكتورة آفاق وكل الناس اللي كانوا standing behind الeffort العظيمة دي. Thank you all for this يعني very important event. يعني الليلة خليته يومنا سعيد والله، وشعرنا بإنه we are doing something to our country. Thank you very much.